So I think we'll make a start. So hi everyone, and thank you for joining this event on the future of research on adverse childhood experiences. I'm Jessie Baldwin and I'm a postdoctoral researcher at UCL. And I'll be chairing this event today with Andrea Danese, a Professor of Child and Adolescent Psychiatry at King's College London. And we'd like to thank Dr. Rebecca Lacey from UCL for all of her help in organising this event. Unfortunately, she's unwell today and wasn't able to attend. So this event is the first organised by a new ACAM special interest group on adverse childhood experiences, or ACEs. And I'm sure as many of you will be aware, ACEs refer to experiences that require significant adaptation by a child in terms of their psychological, social and neurodevelopmental systems, and which are outside of the normal expected environment. So this includes experiences like abuse, neglect, dysfunctional home environments, and other forms of trauma that children experience. And it's really well known that ACEs are associated with a higher risk for having mental and physical health problems, as well as other poor functional outcomes. There's still a lot that we don't know about ACEs. And so the aim of today's panel discussion is to identify priorities for future research into ACEs from a range of non-academic perspectives. And so we hope that this will inform researchers to plan future studies and grant applications to better understand ACEs and their effects. So on the panel today, we have a policymaker, we have a young person with lived experience of ACEs, and we also have representatives from the Early Intervention Foundation and the NSPCC, which are two leading charities aiming to support young people exposed to adversity and prevent them from developing poor outcomes. So the speakers will address two main questions. So firstly, what are the priority areas for future research on ACEs? And secondly, what do they hope that we'll know in 10 years' time about ACEs that we don't know already? And following their 5-minute presentations, we'll then have a Q&A session with the audience. So get thinking of questions while they're giving their talks, and feel free to post them in the Q&A box, and we'll do our best to get to as many of those questions as possible. We'll then hear more about how to get involved in the ACAM special interest group on ACEs. Okay, so I'll now hand over to Andrea to introduce the speakers and discuss some housekeeping points.
Great. So thanks very much, Jessie. And also, again, thanks to Becca Lacey, who with Jessie has organized today's webinar, but unfortunately cannot be with us. So I stepped in to help. I'm Andrea Danese, and I'm delighted to welcome our 4 panelists speaking today. First, we'll hear from Jill Wily, who is an experienced public servant based in the Trauma Adverse Childhood Experience and Resilience Unit for the Scottish Government. Jill is passionate about making a difference for people who are experiencing social and economic inequalities. Next, we will hear from Susan Cookie, who is Head of Research and Evidence at the NSPCC. And Susan is a social researcher by background and has worked in research and evaluation roles within international development and children's and humanitarian charity sectors. We will then hear from Kirsten Asmussen, who is Head of What Works in Child Development for the Early Intervention Foundation. Kirsten made a leading contribution to a comprehensive review in 2020 by the Early Intervention Foundation on evidence about ACEs, entitled What We Know, What We Don't Know, and What Should Happen Next, which is very topical for today's discussion. And finally, we will hear from Megan Briggs, who is a survivor of child sexual exploitation. She now works supporting and advocating for victims of crime, and as a lived experience researcher. After that, we at about 2:30, we will begin a question and answer session. And you can type your questions in the chat, and we will do our best to ask the speakers as many of the questions as possible in the time we have available. And around 3:20, we will then hear more about the special interest group at ACAM on ACEs and how to get involved. I will now hand over to the first speaker, Jill, and I really look forward to the presentation. Thank you.
Thank you, Andrea. I hope you can all hear me. Yeah. So thank you, Andrea, and thank you everyone so much for inviting me along today. As Andrea said, I'm Jill Wily and I work as a policymaker in the Scottish Government's Trauma, ACEs and Resilience Unit. I think it's worth starting by saying that, we use the long-standing ACEs research as a basis for our daily work with a wide range of policy areas across the Scottish Government, working on a whole range of complex and wicked issues, including homelessness, mental health, education and justice. Critiques and I think emerging evidence over the time that the unit has been in existence have meant that we've refined our approach over the years. So, for example, our definition of ACEs in the Scottish Government goes beyond the original 10. We make it very clear when we're talking about it that those poor outcomes are not inevitable. So we don't take a deterministic approach. We also take account increasingly of the wider social and economic context and inequalities. So for example, at the moment, we're working very closely with our colleagues who are working to tackle child poverty in Scotland, and there's a new report that's about to come out in the spring. And then finally, the other point that's just being clear about upfront is we do not, and we haven't ever advocated scoring on the basis of the original ACEs research. So I think, as we all know, that original research was really powerful and really accessible to a wide range of people. And as elsewhere, it generated a huge groundswell of interest and engagement. But I think it's clear that it was not perfect. It's very focused on the potential life course impact of ACEs and focuses much less on those structural causes or the structural factors like poverty and social inequalities. And I think as a policymaker, the body of evidence also focuses less than I would ideally like on effective policy and practice interventions. And increasingly, we bump up against policy colleagues who are asking us, well, we know about the research, we've known about it for a while, what does that mean, what works? And I guess all of this really matters for lots of reasons. There's serious, complex and intractable issues that we're talking about very often. So there is no quick fix, but we know increasingly, and we've known for a while, that we need to move further upstream and prevent the poor outcomes associated with childhood adversity from happening in the first place. And I think when I was thinking about today, I was also thinking, increasingly we will be operating in a very tight fiscal climate. It's likely that budgets as we emerge from the pandemic will be even tighter. And I think asking the questions today that we're asking ourselves today are really timely, because I think there'll be an increased call from budget holders for us to be really clear about what works and to make that shift upstream. And of course, as we emerge from the pandemic, those exacerbating levels of stress that people are experiencing, and the pandemic also exacerbates people's ability, I think, to deal with that stress. So the first question really, which was all about what are the priority areas of research for ACEs, again, was really timely for us because we're currently thinking about developing a strategy for the ACEs and trauma work in Scotland. I guess in the light of what I'm talking about, it feels like there's a really well-established awareness with the original ACEs research, but this feels almost like a pause. It's almost like, so what next? And I think that's the role that the strategic thinking that we're doing will perform. So there's still so much that we don't know, or maybe we don't know well enough. And clearly, as policymakers, our overall role is to improve the lives of the people of Scotland. And it really matters to have the evidence and research to help us do the right things and to be clear about their impact. So in terms of that first question, I think my thinking is really just a few thoughts. So firstly, I think we need to understand better how do we best intervene to prevent ACEs from happening in the first place? In what way and when, for example? So are there especially sensitive or important periods in childhood or adulthood to intervene? And what's the role of awareness raising in all of that? Linked to that, I think there's something about, can we better understand the role of, I'm not a great fan of resilience, but maybe call them protective and buffering factors in preventing and mitigating ACEs. And in particular, we're thinking a lot in policy terms about the role of that single trusted adult, and also about sports participation for children and young people in particular. So how should we target these as policymakers to maximise their impact? And do we know enough to do that right now? Thirdly, I think there's something about an increasing shift to positive childhood experiences. So more of an asset strength-based approach to what we're talking about, so that it's really not just about what happened to you in the negative sense, but thinking in policy terms about the things that should have happened to you and what is our role as policymakers in that. And equally, there's something there about what's the role of communities in that. As I said, we know that the wider context matters, so understanding that sort of interplay between the social and economic inequalities matters. And I think if we understood that better and how they interacted, again, we would develop better policy approaches to that. And then finally on this question, I think there's something, again, really topical about the impact of COVID, clearly, but also other issues and events, Ukraine, for example, the climate crisis, the rising cost of living and benefit cuts. Something about what's the impact of these going to be if we look 10 years into the future. It seems likely to me that they're going to exacerbate the situation for many at a time, as I say, of like tight budgets. And then moving on to the second question. So when I was thinking, what would I like to have in 10 years' time as a policymaker that we don't know now? I think I would really love to be in a position where I'm able to advocate a really clear set of the best evidence-based interventions, both universal and targeted, that prevent ACEs from happening in the first place and that mitigates them too. So to have a really clear idea of what makes a real difference and improves people's outcomes. And I think linked to that, and it maybe goes back to the resilience screenings, is having some really good stories to tell would also be really, really important and powerful. Evidence-based stories about how certain policies and practices have changed people's lives and reduced the stigma around often the very issues that they face. And then linked to that, it's not just about the what, but there's something too about the how. So I want to know, I think as a policymaker, what helps and hinders people in terms of accessing and engaging with the interventions that we design. And we talk quite a lot in Scotland these days in service delivery terms about there being, no wrong door, no wrong place, no wrong time. That whole thing about meeting people where they are, because we could do all sorts of amazing research and understand what wonderful interventions are, but there's really no point in having those great interventions if people don't or can't use them, often for reasons that maybe aren't even that visible to us. So I think whatever we design needs to be designed in a real world with the needs and voices of real people and lived experience front and centre. And we need to know much more in 10 years' time too about the impact of trauma-informed workforces and about the power of that relationship and connection that underpins a lot of it. And then finally, you won't be surprised to hear, given that it's a bit of a theme running through what I'm saying, I think there's definitely something as a policymaker about wanting to understand how to prioritise and link our work in that wider context. So definitely about having a much better understanding and clarity around the interplay between ACEs and those structural and social inequality issues that I was talking about. So I was conscious when I was planning this that 5 minutes is really nothing at all. I could go on, but I suspect I'm out of time for now. So just thank you once again for inviting me, and I'll hand back to you for now, Andrea. Thank you.
Thank you very much, Jill. And I'm sure we will have much more time in just a few minutes in the question and answer to expand some of these important points that you have made. And again, a reminder, if you have questions, please use the Q&A box at the bottom of your screen so that we can then discuss all together later on. But we can now move to the second speaker, Susan, and I'll leave her the floor.
Thanks, Andrea. And thanks, Jill. That was really interesting. And I think there's some overlap between our priorities, which is actually quite reassuring. It's quite good to know. I am going to steal about 30 seconds of my valuable 5 minutes to talk a bit about research at the NSPCC, but this is, I promise, very useful background to what we're going to be talking about next. So NSPCC, it's a UK-wide charity, and we're looking to prevent child abuse, to stop it, and to mitigate the impact on children when it happens, in a nutshell. And for us, interrogation of the existing evidence base, but also generating our own research, partnering with academics, all of that activity is really essential to how we develop services, how we develop our policy positions, the campaigning work that we do. The overall aim is very, very broad. We want to prevent child abuse and neglect. We want to stop it when it's happening. We want to reduce that impact on children when it does happen. So our focus is in some ways narrower and wider than ACEs, depending on how you define child abuse and how you define ACEs. Much of our research up until now has focused on responding to abuse. And I think that's partly because we've done a lot of evaluation research with our own services, which are about responding, about making things better in difficult situations. And we have a grant we administer with the ESRC, which is all about what works after abuse has happened. But we are shifting to focus in prevention in our new 10-year strategy, and that is going to affect our research focus as well. So that has influenced my choices here. So I chose these two priority areas from a very long wish list. I've chosen some less explored areas. I mean, none of these are untouched by research, and certainly not by policy discussions, but they're areas we'd like to understand more, or where we'd like to consolidate what we already know. And the first is about neglect. So the most commonly reported, but also sometimes most slippery to understand and address form of child abuse. And it's about preventing that collectively. I think a lot of the research around neglect is very focused on the personal and the domestic, what happened in the home, what happened in the parent-child relationship. And of course, that's crucial, but I would think it underserves that wider context, as Jill mentioned, structural factors, systemic racism, intergenerational poverty, and most important, I think, to NSPCC, a shared responsibility to prevent neglect. We have a few place-based initiatives called Together for Childhood that work very locally on ward level from the sort of ground up with communities trying to prevent child abuse. And we're really trying to understand how can that actually happen. We also, this would have very practical application for us in terms of assessments with families. NSPCC has designed some assessments in the past, and they do not always take into account that wider societal context that a family lives in. And it is so important to get that right. I mean, this is the means whereby is determined what support families will get, whether children will be allowed to remain at home. And it's crucial to have that wider understanding built in there, particularly around neglect. My second question is about help seeking and about how ACEs influence the way children seek help. As part of their wider intersectional identity, gender, sexuality, disability, other characteristics, how does that all work together to influence the way they seek help? And that's particularly important to us because we run a helpline for children, we run online assets where children seek support, and we want to know that those children who most need the help are indeed wanting to engage with the sort of help that we provide, and that we are actually reaching children with all these different intersecting identities and challenges. So that is a really key one for us. I realize I'm running low on time, but there was another element to that is I want to understand how children conceptualize ACEs and how they understand those experiences as part of their identities and how they define themselves, and just to hear a bit more from children on that topic. The second question is what I hope we will know in 10 years' time that we don't know now. And I really want to know what will have changed, because we've already had more than 10 years of fantastic work, this dedicated work being done by the Scottish and Welsh governments, a lot of research around ACEs, protective factors, risk factors, ACE-aware schools, local authorities, training, and what difference has it made? it can take, a generation to see a real sea change in the way children's behavior is understood and responded to. And yeah, I'm just wondering, will adultification bias be a thing of the past? Will there still be children in prison? What will children's school experiences be like? Will bullying have vanished in the home? Will this understanding of ACEs have created a generational shift in parenting practice? So what I really want to look at is the long-term impact and the societal change that is wrought by all this fantastic work that has been going on. So I'm aware that I have run out of time, but in a nutshell, those are the priorities I wanted to share today.
That's perfect. Thank you so much, Susan. And in rapid succession, we're moving down to Kirsten for her presentation and ideas.
So I too will just start out with a little bit of an explanation. First of all, I want to say I'm really excited to be part of this and very pleased that so many people have joined. Just to say quite briefly who we are, what's a What Works organization? Well, it's our job to kind of look through the evidence and decide what the best and the strongest evidence tells us about what works in terms of interventions for improving child outcomes. But we also, and I think it's fair to say, in terms of looking at the ACEs evidence, we've been trying to figure out what the robust observational evidence tells us about children's development more generally. And so, as Andrea started out by saying, we published a report now 2 years ago, it feels like a decade ago, on ACEs and what we really thought we knew and what we still don't know and what we think should happen next. And then what we did after that was we actually ran a Delphi consensus exercise to find out, everybody, I think all the organizations on this call participated in the exercise, plus charities, individuals with lived experience, et cetera, to agree a set of recommendations to go forward. So I'm going to discuss that quite briefly, not the findings from that, but what I'm saying here is going to be informed by that consensus building exercise, as well as a piece of research, which I'm not going to talk about so much today, but we just finished a study with What Works Children's Social Care to look at the potential effectiveness of trauma-informed care and how it's currently used in the UK. So in terms of priority, I'm going to say I was really happy to say here that people aren't scoring anyway, and I feel like maybe I'm preaching to the choir now, but on the basis of a statement that Robert Anda came out with just shortly after we published our first report, and research that Jessie has been involved with, and Andrea, and just today on blog, at EIF, we published a review of the most recent study that looked at the predictability of ACE scores within the original population. I think, as far as I'm concerned, from a What Works perspective, ACE scoring doesn't work. It's something that we probably ought to stop doing for the time being. And if we are going to continue to look at the impact of adversity on various child outcomes, I think we can do a lot better than we have. And when we do that, we should be remembering really some core scientific principles when doing this, and making sure that anything that we develop is, the wonderful thing about the ACE score was incredibly intuitive and simple to understand, but it just didn't have the sensitivity and specificity that we need to do this with any level of individual predictability. And that's just so essential, which also gets to, this is my new pet peeve, is scientific spin. In what I do at EIF, I read, probably fair to say, up to 100 new research articles every month. And these articles, there's the discussion section at the end, and you try to put together some ideas as to why what has happened is happening. And this certainly was the case with the ACE study. And I remember when it came out 20 years ago, those findings were very interesting. They were quite provocative. But I think that story that they put in the discussion section became a fact that was never proven. And I think that this is, and unfortunately, I see this happening more and more in research articles, that that discussion section there's more and more conjecture as to what the findings of a study might mean. And I think that that's because people are worried about the impact factor, which is an important thing to be worried about. But on the other hand, it might lead you to come to some conclusions that are just not supported by the evidence. And I'm saying that this is a moment to stop and think, well, let's make sure that we are confident in what we're saying, and not oversimplify. Oh, here we go. A second, and it's been already said today, I'm going to say it again, is we really need to deepen our knowledge about the causes and consequences of child maltreatment. And that's really at the core of what we're talking about with ACEs here. We need to improve our methods for measuring child maltreatment prevalence. When we first started that study, it was amazing to me how imprecise those statistics are. And all of us are relying on the very important prevalence study that the NSPCC did over 10 years ago now. NSPCC, if you want to do it again, that's part of your priorities, and you're shaking your head no. I mean, otherwise, this is something also the UK government is looking into. We've got better methods now than we had in the past. I think we've figured out, there are a variety of good examples that I've heard of since our report was studied for how you can do this in a way that's ethical and keeps children safe. I think it's really, really important that we know live how prevalent ACEs are, and get a much better picture of that. And when we do know that, then we'll have a better understanding of what the causes and consequences are too. We need to also know more about how deprivation and threat influence children's development and the role at which ACEs and other adversities, I'm not just talking about the traditional 10 here, but things like poverty, et cetera, impact children's development. And then going into, and just to kind of show you how messy this is a Venn diagram that was printed in a recent study conducted by Dante Cicchetti's team at the University of Minnesota and at Rochester. And just to show, I'm not going to explain it here, we don't have time. This is just to show how complex these concepts are. And that, so in the very middle there, you've got sexual abuse, which is incredibly devastating, and all of the other adversities and all the other forms of child maltreatment tend to pile on that. And then we have other things like emotional abuse, which are also very impactful, not as much as piling on it, but some of the outcomes are equally poor. We really need to understand the differences there. And again, emotional abuse might be a marker variable, as it were, for all sorts of other things going on. We really don't understand the relationship between these adversities, or I could have another whole set of 10 other adversities, including poverty, social discrimination, poor birth outcomes, et cetera. We've got to unpick this better, and we need better, bigger longitudinal. Actually, we have some very good longitudinal studies that have considered this. We just need to keep on doing it more. And then, as it's been said already, we need to increase access to evidence-based interventions. One of the things that really has struck us through the trauma-informed care work is how very few of them are being used right now. People are they're spending a lot of energy looking for a quick fix or a silver bullet when it might not exist, and they're not implementing these other things because they're too expensive, let's say, or we don't have the workforce. Well, if you want to stop this stuff from happening, you need to make those investments, and those investments should have a payback. You know, when you look at cost effectiveness studies, they typically do. Child maltreatment is expensive. It's ridiculously expensive. We need to invest more in what we're doing, what we know already. And then also, we shouldn't be investing in things that we don't, we need to develop and test them. We shouldn't be spending money on the things that we have not been developed and tested. And the kinds of testing that we need to be doing is using rigorous evaluation, not shortcut evaluation, because then you could be implementing something that you're uncertain about. Quite often, a shortcut evaluation will actually give you a false sense of confidence, make you think something works when it doesn't. And the things that we develop need to be based on sound observational studies. And again, I'm going to make a plug for really good, long-term cohort studies. So what do I want in 10 years' time, or what do we want? Well, it would be good to know what the relative impact is of various adverse childhood experiences. I mean, this is my ideal wish list, as well as not just experiences, but what are the circumstances like poverty, like living in a disadvantaged community? How do they interact? We can build equations with big enough samples to do that. Also, we need to be, like I said before, we need to understand prevalence, and we need to be able to use that knowledge to better understand who is at the greatest risk of poor adult outcomes. That would be combined with a first set of research. We need to continue to develop effective methods for preventing and stopping child maltreatment. And I take the point that was just mentioned earlier about understanding more about resilience and unpacking that. You know, that's, everybody uses the term resilience, trusted relationship, et cetera. What do we mean by that? You know, I think we really need to develop that agenda more. And I think we need to, you know, at the end of 10 years' time, that's actually relatively quick. We need to know more about, more generally, effective methods for supporting the life chances of the most vulnerable children. And I think underpinning that is really having a good definition of what a good enough childhood is. You know, what are the necessary and optimal circumstances to support children's development? And then I think we would have better services available to prevent some of these things from happening in the first place. So I've said all I need to say now. Thanks for inviting me to this.
Thanks so much, Kirsten. That was really interesting, and a lot of very also challenging ideas that you put forward, and I hope we can discuss a little bit more now. But we now have also a recording from Megan Briggs, and I wonder if we can upload it.
So hi, we're talking to you today about what research needs to be done on adverse childhood experiences. Just to let you know, there will be some mention of abuse, including sexual abuse, poverty and imprisonment, which some people might find upsetting. Please take time for yourself if you need it. So just to let you say a little bit about me, so I was a victim of childhood sexual exploitation, and then I ended up in the sex industry when I turned 18, and now I work with victims of crime, supporting and advocating for them. And I live with my cat Jemima. So when I think about what research needs to be done in the next few years on adverse childhood experiences, I personally think about research that is relevant and, more importantly, will make a difference to the lives of future young people of this country. For me, there's no better way to do this than to create research that holds the government accountable for policies that put our children at risk, such as by reducing universal credit by £20 and by trying to increase women's prison places by 500, to name just two. To create research that is relevant and useful, I believe it's important for academics to join up with people with lived experience and campaign groups to make research that makes a difference. As often it can be all too easy to create papers which are published in niche journals that aren't understandable to most of the population and they're never really used, which might be okay when studying a group of cells, but when you're talking to a person who's often from a marginalised group about something that's often traumatic, I personally think people should try better. I believe these lived experience researchers should be involved from the start of the research with helping to devise helping research questions to the end of the research with analysing data. They will help to reduce the power imbalance and potential harm that can be created by said research, but also know what research will be helpful to their community better than anyone outsider could, and have a better understanding of the issues and nuances of said problem. And finally, to know that these lived experience members should be paid and valued as members of a team. In addition, I think it's important to create research that shifts the blame away from just the bad parents to taking a holistic view of how the government contributes towards people having higher scores too. As in my opinion, and from observing my own and my peers' experiences, I've seen that through universal credit, inaccessible disability benefits, and a lack of joined up supervision for women in domestically violent relationships, people are left with impossible situations when raising children. With a lot of women and mothers feeling like the only way to provide for themselves is to do crime, depend on abusive men, or sex work. And rather than addressing the root cause, the government chooses to ignore them or label them as bad mums, and social services get involved threatening to remove a child. In my opinion, these aren't just bad mums, but mums who are really struggling and were often brought up in abusive homes themselves. As part of holding the government accountable, I would also like research to be done on the treatment of people with higher scores in mental health services in the future. As someone who has a high A score and has been in multiple mental health services and hospitals since 13 years old, I believe that mental health is another area where the government takes no accountability. Through mainly concentrating on promoting schemes encouraging people to talk to their friends, which is good, but ignoring the main issues of underfunding of the mental health services, they again place the onus on the friends and family of the people who are ill, not them themselves. This underfunding shows itself in the over-medicalisation of trauma, with GPs preferring to give out medication rather than actual therapy, as it's cheaper, and the overdiagnosis of conditions like emotionally unstable personality disorder, in especially young women, which comes with so much stigma. So that people who have experienced a lot of childhood trauma end up in a revolving door of hospital admissions, and sometimes even years of involuntary sectioning, as there just isn't enough support in the community for people to heal. So overall, I'm just one person with lived experience, and I would love for researchers to move forward towards talking to more people who have adverse childhood experiences and value their expertise. Second, I would like research that can be used to lobby the government to make changes to their policies and start to try and prevent ACEs in the future, with special note to issues like racism and its effects on ACEs. Basically, anything that can hold the government accountable and takes lived experience voices into account, I think would be great, and moving the narrative away from just blaming parents or the lack of community support. Especially in cases where there have been generations of domestic abuse or sexual abuse, there are often external factors such as poverty which are contributing to this re-traumatisation. Thank you for listening, and I hope you found it at least a bit interesting.
So thanks very much to Megan for this recording. And it's really, of course, very interesting and insightful to learn about her experience. All right, so now we have heard some really interesting and intriguing, I would say, presentation. And what we want to do now is to open the floor up for questions. I see that we already have some questions in the Q&A, which we will go through. Please, again, if you have any more questions, write them in the Q&A and we will read them. To begin with, Jessie, I wondered if you want to start with one of those questions.
Yeah, thanks. And a huge thanks to all of the speakers. Those are really interesting and thought-provoking points. And I hope that we can start to act on some of these to kind of move the field forward. Okay, so one question that we have in the chat, which I think maybe we can direct towards all speakers, is what is an alternative way of assessing or identifying ACEs in individuals if not using the typical kind of ACE score framework or just a yes/no question?
Hi there, Jessie. I don't know if you want me to start with some thoughts. So, I mean, I think one of the things that we were thinking about when we were moving beyond the original 10 is it's quite a tricky balance to strike, but actually it comes down to that association between what's happened to you and the toxic stress response. So I wonder if focusing on that in a more individualistic way might be an alternative. Well, in some cases, you hope it was what would happen anyway.
So, any other thoughts from the panelists?
I would say it depends a lot on the context. Why are you asking the questions and what are you going to do with the information you're getting? Because we all know the shortcomings of the ACEs questionnaire, that it doesn't look at context or the length of time for which something happened or the number of occurrences or protective factors, risk factors. But to have a more expansive interview with somebody, is it in terms of determining support that they need, or is it for research? I think there isn't necessarily one size fits all question. It depends what you can do with that information. I mean, I've seen reports where entire schools in the United States are doing ACE questionnaires for the population of children. And my question would be, to what end? So I think the question, sort of turn it back, is to say, what are you going to do with that information? And that will determine the questions you might ask.
Totally, I think that's such a good point. Kirsten, did you want to add anything? Or?
Well, just to pick up on the points that have already been made, I mean, much of the ACE scoring was the idea that you could do population-wide screening, much in the way that you might do for other things like breast cancer screening, you know, at a certain age where the sensitivity and the specificity, I don't want to get too technical here, but it makes sense because you have something that you know that you can do that will make the outcome better. And you also have a test that's good enough for detecting something that could be problematic almost 100% of the time. We also have some measures, for example, of depression that makes sense at a certain time in an adult's development or a woman's development that have that same level of sensitivity and specificity. The question is then, do we have interventions that will be suitable? When we have that answer, then I think maybe we could start considering it. The other thing is, again, as has been already mentioned, you know, what are we going to use it for? There are validated measures of trauma out there that when you have good reason to believe that somebody has experienced something highly traumatic, that using them makes sense. That's not population-wide screening. Maybe that's too late. On the other hand, I think some of these things we have to wait for some of those circumstances to avail themselves, rather than thinking that that this magic bullet like screening exists. And I think that was what was very interesting to us in the research that we did, is that the assumption is that nobody minds being asked these questions. The fact of the matter is the most vulnerable people do. And so there's quite a bit of training that needs to take place around that too. And until we have that in place, I don't think we're ready. We're just not there yet.
Absolutely. And I guess beyond, right, the yes or no question, of course, there is a long tradition of important investigations, both in terms of child maltreatment and parental mental health, that has been going on for much more than 20 years, right? That has been measuring elements that now we call ACEs. And so, of course, what the ACE has done is to simplify the measurement of all this factor as much as possible to apply it to population screening, as everyone has said. But there are a number of limitations. So in many ways, there are many alternatives to just asking a yes or no question. And there are much more intensive and valid ways of asking these questions. And I suppose you get what you put in assessing ACEs in this way, right? So it's advantageous because it doesn't take a long time, but then in terms of the validity of all the information we get might be quite limited, as a recent paper have been highlighting. Before we move to the second question, I wanted just to point to all participants that would be fantastic if people could put their questions in the Q&A box instead of the chat, just because that gives us a way of actually monitoring the questions being asked. That would be really, really helpful. And sorry if that means just copying and pasting between the chats and the Q&A. But building on what we were discussing, I think one question points to the fact that there are alternative ways, again, in which ACEs and trauma have been assessed. So there was reference, for example, to the ICD-11, right? The diagnostic system that the WHO has developed. And one of the questions is whether we believe that the use of the 10-item ACEs questionnaires is enough to inform practice and policy. So I think we have covered already some of these points, but I wondered if we can take that as an opportunity to expand on some of the points that we heard from in the presentation. So I heard some positives about using the ACEs for informing practice and policy, but also some reservations. So I just wondered if we can expand a bit on that.
So maybe it would help if I say a little bit about how that original ACEs research landed in Scotland and what it's kind of meant for us. And it also perhaps picks up on one of the questions in in the chat box. So, I mean, I think way back in 2016, our unit started off with Sarah Dodds, who's now the unit head, and Sarah was kind of working on her own. And at that time in Scotland, I think awareness of the ACEs research really took off in two separate ways. I think probably both top down and bottom up. And the bottom up approach was really coming from screenings of the film Resilience, which again is not entirely without its issue, not least that it's based in the States. But there were a whole series of screenings of the movie Resilience across Scotland that about 2,500 people went to, that it was very accessible for people at all sorts of different levels, both practitioners and just members of the community. And what I think fell out of those screenings 5 years ago now were 32 local ACE hubs across Scotland, one in each local authority area across the whole country. And in many ways, they have developed in different ways, but they have kind of almost kept the light alive at a very sort of bottom-up approach. And then I think allied to that and happening in tandem with it, to some extent by chance, was much more of a kind of top-down approach. We have a national performance framework in Scotland that's been in existence for about 15 years now that is broadly unchanged, and it provides a kind of steady, constant light guiding the work of government here. And within the 15 national performance outcomes, there are 3 that are particularly relevant to this work, which would be firstly about growing up loved, safe and respected to fulfill your full potential as a child. There's one which is all about tackling poverty and sharing wealth and power more equally. And there's one I think that's also relevant about, you know, growing up in communities that are safe, empowered, resilient, and I think the final word is inclusive. And around the sort of bottom-up approach that came from the research and that kind of top-down steady light of the national performance framework, I think I'm deviating from the question, but I think what I'm trying to say is this is not subject to the sort of vagaries of governments. I think this is something that is pretty steady, and our intention with developing the strategy is thinking about that even more.
Absolutely. So that's an important reason why this focus, right, is important to inform practice and policy. Mm-hmm. I wonder if Susan and Kristen have anything to add, or we can move to another question.
I've forgotten the question. I was just listening to Jill and being, oh yes, that's interesting, and now I've lost a thread.
Absolutely. And so just I suppose we were, one question was asking to expand on what are the advantages and disadvantages, I suppose, of using the 10-question ACEs screening as we currently have it. And as I said, something that we have covered in good part of the presentations, but anything that you wanted to add to that? Okay.
Okay, so I think a few of the panelists mentioned about preventing ACEs and also about tackling some of the wider structural causes of ACEs, so things like socioeconomic factors. And so we have a question that in terms of poverty as a potential issue to target in relation to prevention of ACEs, don't we already know enough about child poverty and its effects from research? Would you agree that the wider problem is more the political willingness to engage with this? And they say, I suspect that if we do more research on poverty as a predictor of ACEs, we would struggle to get it funded, as funders would say we don't need more research to show that poverty is bad. So I wonder what you might think about the kind of key research focus in terms of maybe poverty as a contributing factor to ACEs, or perhaps interventions addressing poverty. Oh, you're muted.
You're muted, Chris.
Here. One question I have, what's related to that is, I mean, okay, so yes, poverty is a key amplifier and probably a cause of some ACEs. Does poverty in and of itself cause trauma? Does poverty in and of itself weaken the immune system? You know, maybe yes, the answer to that question is yes, but then if governments need a economic rationale and we can say by how much, I'd be happy for that information. I'd like to know more about it. And also the bigger question for me is, if everybody agrees that poverty is an underlying causal factor, then go back. Why aren't we doing anything more about it? What is it about? Why have we only got in countries like the UK as far as we have? We do know that in other countries where it is addressed more explicitly, in many instances, child maltreatment is less. Now, can we say robustly, is that the only reason why? Perhaps not, but there are plenty other smaller studies that would suggest that that's true. So the question for me is, okay, why isn't that? And the other question is also, I guess, about this ACE narrative and stuff. How far have we gone with that? We've increased awareness, but have we improved policy? Have we improved interventions? I don't see that happening. I see instead things replacing the interventions that we know might make a difference already. We haven't knitted those things all together. Alongside with poverty, are we doing other things that could mitigate ACEs? For example, restricting the availability of alcohol. We know that does make a difference. How does that policy, where there's a huge industry underpinning it, interface with our knowledge of ACEs? Those two, from my perspective, haven't been knitted together yet.
Yes, to pick up on what Kirsten was saying, I agree. And I think with poverty, yes, we know poverty is a factor, but how well do we understand that quite complex causality between poverty, abuse, or if you triangulate with drug and alcohol misuse, mental health? I don't think we want a really simple narrative. Poverty causes child abuse, or poverty causes ACEs. Poverty, it is an ACE. And while, like Kirsten said, there have been small studies showing just increasing a family's income, for example, can reduce risk factors for child abuse. We know that. And I think the questioner said, we all know this. I don't think we do all know this, though. I believe there's quite a distance between the research community and people like me working in the children's charity sector and public perception of what it means to be poor and adverse childhood experiences. And I think government will probably not make the significant changes we're talking about until there's also that shift in public opinion. So it could be a question of more research about making those shifts in thinking. This is sort of why I asked my generation later question, because it seems to take a very long time for these things to trickle down. And is there a responsibility for researchers to be, playing their part in the knitting that Kirsten mentioned, which is, full of holes at the moment?
Yeah, that's a really interesting point about the kind of temporal and causal relationship between things like poverty and ACEs. Which comes first, and how do they kind of interact with each other and get passed on over generations? Because I think that there is quite a lot of research showing that poverty is associated with ACEs and vice versa, but I don't know that we know which causes what, or if they both cause each other and things like that.
So another question here is building on what Susan was suggesting in terms of really expanding the way in which we understand how children conceptualize ACEs. And I think that's a very interesting one, because of course, not only the original ACEs questionnaire was developed for and by adults, but we see that there is incredible heterogeneity in the way different people and different children respond to ACEs. So I just wondered if we can just make some reflection on how we would want to approach this I suppose, research priority really with children, and how we can work with them, involving them in such a delicate and important research, right? In terms of understanding, in many ways, their own subjective views and experience of ACEs, and probably trying to understand what is the matter to them at that time, right? Again, what we're doing is trying to use a lot of research that has been done in adults on retrospective reports and applying that to the lives of children, right? So there is quite a translational divide in the research and what we're trying to do in practice. So I wonder if there was any thoughts or reflection that we can make in that area.
I think in some ways it's a huge question because it covers all research we do with children about abuse. So I'm not going to sort of go down that particular route, but in terms of children's understanding, ACEs, it looks back. It's very much a looking back tool and a looking back approach, and what is the impact now. Children's understanding, and not necessarily children's understanding in the moment, but even while they are still children, and how they conceive of those experiences, what they would call them, how they would name them, just on a point of principle, I think is important to understand and include. But there's also, I'm a bit concerned about, I see increasing sort of teaching in schools. Part of the trauma-informed work is, these are things that happened to you as a child. This is the impact it had on you. And there can be some very simple deterministic messages, which I think can be quite harmful for children. And not all of those programs, I saw someone asking about, toolkits for schools. They're not all created equal. And I think it's imposing a framework on children, like you said, designed with adults, for adults, and it hasn't taken into account how they understand these things. So for me, it is more about that understanding, that cognition, as opposed to necessarily digging into all children's experiences at the time of ACEs. We do know a lot about that, but can also that be brought over into the language, into the dissemination work?
That's very helpful. Any other thoughts, Jill?
Just to share. I mean, as a team, we met with the Scottish Youth Parliament last week, and I think for us as policymakers, it was really good to think about that, how that engagement was designed. It's often very, in a traditional way, I might go out and do a presentation, people will listen to me, and then there might be this sort of setup with Q&A afterwards. But we consciously designed it in such a way in that it was a call and response session, and it was very much led and shaped by the young people themselves. And I think that the things that struck me from that was they were intrigued and they were happy to talk about it. And the feedback was very much about, we need to know more about this, we need to understand it. But there were also themes coming up for them about, talking about it needs to happen in safe, trusted relationships. And it's about having those conversations with people that you know and trust. And they were quite interested in talking too about resilience factors, protective factors, and about the adults that were important in their lives and what role that might play. So yeah, it was just interesting. And I think probably as policymakers, my reflections on that were we need to talk to people more, young people more. Got an awful lot out of it.
And of course, as I was saying, it is as important as it is challenging, right? Particularly when we talk about this very sensitive content, but we need to find ways that probably from my point of view is one of the research priorities, how we can engage young people in this conversation, particularly if we learn as we are that what seems to count is really the cognitions around these experiences more than necessarily potentially even the experiences themselves, right? So it's really important to develop this area of engagement and participation of young people in these areas of research.
Definitely, and I think that was a really nice point highlighted by Megan too in her talk. Okay, so one quite topical question when we think about the impact of COVID on funding for kind of prevention and early intervention schemes. So for Jill or anyone else, what do you think about how to protect early reduction and intervention efforts from the vagaries of electoral and economic cycles, and given the financial pressures that we're going to be under over the next few years?
So I think this ties back in a little bit with what I was talking about earlier in terms of Scotland having that national performance framework that has remained unchanged for like a decade and a half, and is that kind of guiding star as we move forward. Underpinning that, there's a kind of, we also have our programme for government each year that links back to the national performance framework, and ACEs and trauma work are explicitly spoken about in that. I think the other thing that's perhaps worth mentioning in this context is the Christie report in Scotland, which is a decade old now, and it talked extensively about shifting public sector spending upstream. And I think the fact that here we are a decade later and it's really hard to point to that happening on any big impressive scale shows how incredibly difficult it is. And I think, as I was saying in the presentation, it's only going to get more difficult with tighter budgets. Christy talked a lot about demand reduction. So unless you're able to shift that funding up front and prevent some of these difficult things happening, you will then end up spending, just in financial terms, taking the kind of other stuff out of it, you will then end up spending huge more amounts of money further down the line in terms of dealing with the consequences of what has happened to people. But it's really, really difficult and really intractable. So it's interesting. I always think of Wales quite often in these sorts of discussions too, because I love the fact that they have got Sophie Howe as the sort of future generations commissioner, because actually I think that also is something that helps with getting beyond the electoral cycles and what politicians are maybe preoccupied by in a term of government. Having someone that is in that position, that is really thinking not even the 10 years ahead that we were thinking in our presentations, but beyond that, is really valuable and really important, and ought to be part of government as standard, in my opinion.
Thank you. Any other comments from panelists?
I have here a question for Kirsten particularly, but of course everyone is very welcome to add to. I suppose it's actually two questions, more or less on the same topic, which is trying to make sense of what we're saying in terms of the difference, right, of seeing the research on ACEs replicated so much. And that is one of the strengths of the research on ACEs, right? Many different samples have replicated the association between the ACEs scores and some of these mental health as well as physical health outcomes. And what we're saying now, which is, I suppose, raising caution in terms of using the ACEs questionnaire for individual risk scoring and individual intervention, so the allocation of intervention to individuals. I wonder, Kristen, if you can expand a little bit just to clarify that point.
Yes, it is for predicting individual risk. I think that...
I guess, sorry, just to say, I guess the question is, how can we reconcile, right, the finding that is so replicable, but we're saying is actually perhaps not what we want to do in practice, right?
Well, certainly not to predict individual risk. I think as a population screener thing, I mean, basically the 10 questions were from the conflict tactics scale. That was a population screener. It was developed, it was good, it was useful. It was never intended to predict individual risk, but it really, I mean, I don't want to get into the statistical reasons as to why you can have that level of error in a population-wide screener. And as far as, you know, the WHO and the CDC in the United States really have used it and similar questions as a way to find out how, for example, at a policy level in the United States, what's differentiate, you know, how do the states differ in terms of their ACEs as well as other factors that they look, they've used it with the entire population. So they've got huge statistics there that they can run regressions on, and it's quite useful to test in that respect causal relationships and make comparisons. And so I think it would be fair to say that when there is a lot of adversity in various circumstances, that we're going to see a variety of different public health problems, and poor physical health is going to be one of them, and poor mental health, which has been very, I mean, I think what was interesting for us is that given that error, we saw that the ACE questionnaire paralleled quite closely what we know in longitudinal studies about the progression of mental health problems and the relationship between child maltreatment and poor mental health outcomes. But maybe some of the, and again, this gets back to statistical reasons, the relationship between very common poor physical health problem outcomes like cancer, even at a one point in time snapshot questionnaire, you cannot decide what causes what. And these are very important limitations to that study. So we're seeing something quite crude there that might tell us something about a population, but is not going to tell us about something about an individual. And so we need to either get better at that or maybe even try something entirely different, because we shouldn't necessarily start with questions that weren't intended for that purpose to begin with. And so what we might want to think more carefully about, if you wanted to think about who is at greater risk, going beyond those 10 questions, which are very centered on child maltreatment, you might want to pick one question about child maltreatment that's quite predictive, and then add some other things on there. For example, were you a premature baby, and look at those sorts of things, and might have a better predictor of individual risk, for example, physical health outcome, than what we have right now. And so I hope I'm answering that question without getting too technical, because I think that's the problem. But
Sure.
Yes, when we say stop ACE scoring, we're talking about at the individual level. And then, they like these global score cheat cards. As far as that's concerned, I don't think that there's a big problem with that, but not for an individual.
And I suppose what you're highlighting is that at the individual level, using this scale is inaccurate, because we have a lot of people who would score high on ACEs but don't have the outcomes, and a lot of people who score low but will have the outcome in the future. And therefore, allocating resources based on the screening then might become problematic at the individual level. But at a population level, this has uncovered, of course, a number of interesting potential targets for population level prevention, right, of these experiences.
Yeah, so you see a lot of ACEs, and you see that they don't have very good public health policies in terms of welfare. This is where you can maybe see these big macro changes based on those policies. We need to consider that, remember that, I think. And some of that's going on already. Actually, some of that research goes on already, but it doesn't capture the imagination of people as much. And one challenge that I would have about some of these narratives is, even though they are eye-openers, what if that narrative isn't true? Or it's only partially true? I mean, I'm going to really push on this because we don't want to, and, as I've already been mentioned, these narratives can be deterministic at the individual level. I just think, speaking for myself, my folks split when I was 18. And all of a sudden I'm finding this is an ACE. And then you start re-examining, well, is something wrong with me? What was my lived experience of it at the time and versus now? It does increase awareness, and that could be helpful, but it may not be. And we need to understand that better as well.
Thanks very much. Yeah, that's really helpful.
So another question is that many of the panelists, and especially Susan, spoke about the need to prevent ACEs. So what do you think some of the most promising interventions are to prevent ACEs or maltreatment? Or if you think that there aren't really any at the moment, what kind of avenues do we need to go down to identify those interventions?
Was that directed at anybody?
Well, I wonder if maybe Susan wanted to jump in, as you mentioned it being a key priority for the NSPCC.
I mean, Kirsten will have the library of what could work stored in her head, so I will definitely good to go to her next. I mean, this is why we are shifting toward prevention. There's a lot we still don't understand. I mean, you could reverse the cut to universal credit, as a few people have mentioned, in terms of reducing adversity more generally. But preventing ACEs is a really wide range of experiences that happen to children, and they happen for so many complicated reasons. You could pick one thing. You could say drug and alcohol support for parents. Focus on that. That will have a huge impact. Okay, but that is one corner of it. And it is, we all saw the chart that Kirsten shared. It is so complex and multi-layered. And as the NSPCC, we haven't got our mind around yet what the role the charity sector can play. I think, for governments, it is slightly easier to talk about large scale change. But we're still working on it. In terms of interventions, we have individual interventions that have shown to be individually promising, but large scale change on the basis of those interventions. Kirsten will be the one to answer that, I think.
Unfortunately, the first answer to that question is that, going back to there's no silver bullet or quick fix. It's, right now, the current public health thinking on these things is that you take a public health strategy and you have a range of things with efficacy, starting at universal policies, for example, various tax credits or things that will reduce the economic burdens, policies about drugs and alcohol, maybe some public awareness campaigns would be beneficial, and then you go right up. But at every layer, there are things that have been shown to be effective, and they're not being used right now. So are we using the credits that we can as effectively as possible? Are we providing enough awareness? For example, I think one thing that struck me, and we're looking at this from another angle right now at EIF, is there are now a range of interventions out there to improve, to reduce family conflict in parents, whether or not they're together. Could we be implementing that more widely? A lot of people separate. Could we be making that available at a time that would reduce the level of destructive conflict within families that takes place at the time of parental separation? Are we making sure, for example, that the interventions that we offer parents where one or both might have a mental health problem is also providing benefits for children? We do know that there are some of those out there. We do offer quite a bit to individuals with mental health problems, but we don't pay attention to the child. Maybe we need to pay attention more about what we're doing already and how children are benefiting from that to understand that impact as well. So I think we need to have a menu, I don't like using that word, but a range of interventions available at all different levels. And those interventions need to have some evidence of being based in some scientific observations and shown to work where we can attribute causality to them, but nobody's using them right now. I'm overstating it, but they're used very rarely.
Sorry, could I add to that, Kirsten? The recent work from Stephen Scott's parenting program demonstrating the significant value and cost saving of sensitive parenting right across the board seems to me one of the approaches which could be valuably rolled out and developed further. Maybe,
but then we could have an interesting debate there, because I think Stephen's research, which I actually know quite well, it showed that it worked for the people who needed it, were having trouble with a child's behavior. So how do we get it to them? And when we do it, I think it does provide many benefits. Does it prevent ACEs though? Maybe not. I don't know, but it may be part of that public health awareness. Then at that level, it might work. I think we don't know. And thinking, going back to what Cochrane said, is that we need to be very careful about when resources are limited, who we offer them to. I think that parenting interventions have a very important role to play in the bigger picture, but in the very small picture about preventing specific cases, if we're going to go back to the traditional definition, I'm not sure.
I think if I can summarize another couple of questions, I guess they take us to the next level of prevention, which is not the primary prevention of ACEs, but the intervention that we could potentially use to mitigate the impact of ACEs. And of course, as we talk about ACEs, what is often discussed is the trauma-informed care that has been developed around the concept of ACEs. And I wondered if there was any pointer that any of you wanted to highlight in the last few minutes we have for the question and answer.
I think I can say a few things that we found out in our research, and that is that people are quite enthusiastic about trauma-informed care. And certainly in terms of offering services to families and individuals who have maybe experienced quite a few ACEs or are struggling with a lot of difficult issues, that striving not to re-traumatize them is a very important goal of the interventions. I think that where the problems start, or you can call them problems, but there's a lot of ambiguity about how best to do that. And the whole movement started in the United States about 20 years ago, where there were a series of studies where they were trying to figure out how you could better retain highly vulnerable individuals, and in particular, women in particular, in services, evidence-based services that were developed with strong evidence for helping them with overcome symptoms of trauma as well as other things. And they came up with a set of guidelines about what those activities would be. And there's even very carefully defined protocols for that. And I think what's struck us is what's being offered in the name of trauma-informed care now is a bit of a departure from that. And so there's been some drift. And the whole idea that trauma-informed care is something that you do to increase engagement in trauma-specific treatments has been lost a bit. But that doesn't mean that it doesn't have value for a workforce, but we need to be very specific about what that value is. So in fact, if it increases empathy for the people that they work with, or if it does lead to policies that are less traumatizing, then those are good things, but then they need to be evaluated, and their value added to families needs to be considered, and the extent to which they work with trauma-specific treatments is also quite important to know.
Yeah, and just to add to that, obviously, approaches in the aftermath, but a key element of mitigation is the response that happens, at the moment of crisis. And the better the support is at that moment, the more you can reduce the impact potentially further down the line. So that children are listened to, believed, that the response is adequate, that the funding is there for an appropriate support, response and support children actually need. That very, very early on action could save a lot down the road in terms of the impact of ACEs. And it's also just people understanding the signs of child abuse and, listening to children. I have to put in a plug for that.
Right. I see we're getting towards the end of the time that we had allocated for the Q&A. So Jessie, can I hand things back to you?
Sure. Okay, so now I'm going to hand over to Arnon Bentavin, who will introduce the special interest group with Douglas and explain how you can get involved in joining up to that.
Thanks. And sorry, Arnon, I should just say a big thank you again to all the speakers today, because I think we had a very active discussion covering so many aspects, right, of ACEs and challenges around ACEs, and just the interesting point around ACEs as well, that we will want to discuss much longer, and hopefully we will have an opportunity to discuss much longer as part of the special interest group. So thanks very much again.
Yes, thank you, Andrea, and thank you to our colleagues who've really been very challenging and interesting to think about the next 10 years. And I'm delighted to see that there are many questions which you have not yet had the opportunity of answering, because this means that they will be the focus for future discussions and for our special interest group to really have an opportunity of thinking together about this important issue. So if I can just play one or two screens just to start us off. Yes, I'm introducing the way in which colleagues can be involved in the Adverse Childhood Experiences Special Interest Group. The goal, which you in a sense have already heard, was established by ACAM with representatives from related organizations. The special interest group is now live on the website, on the hub, with invitations to join and contribute to the forum and to discussions. And the goal is to integrate and develop research and critical understanding of the complex nature of adversity in childhood, formulated as ACEs, and the implications for practitioners across services for children and for young people. So the statement is, we'll review research and critically reflect on the way it's associated with developments across the life cycle, discussion of research papers, key thinking. We've already heard a discussion about trauma-informed care, the whole issue of ACEs as a risk index, population level, and what's needed at a much more fine-grained level at the individual family level. We hope we'll be having regular journal meetings, presenting authors, being able to present to the network, and questions and answers. Publications, we hope, from the UK Trauma Council. We can include preparation of training materials in the long run. There are so many particular populations where there is concern, whether it's refugee, asylum-seeking children, offending behaviour, looked after children, parenting, so many different issues in this field associated with adversity. And one of the key questions which I was intrigued by that Kirsten brought in was, what will services look like in 10 years' time? What will offending services, what will looked after children, what about mental health services? Will the whole issue of the impact of trauma and adversity be reflected in the way we practice and in the way we work with children, with families, and a population level? Government policy coming into it. So what I want to do is to introduce Douglas Badenoch, who's our keymaster, and he's going to say a little bit about how colleagues can join the special interest group and how they can contribute. So can I hand over to Douglas?
You can, Arnon. Thank you very much. Thanks. Now, I've posted a link in the chat thread with a link to the ACES Special Interest Group Hub page. But what I'm just going to do is to do a quick presentation. I'll show you the process, how you sign up for it, and what the forum looks like once you're signed up. So bear with me. We're going to jump into sharing screens. Now, some of you will be familiar with this view of the ACAM website. It's what you see when you log in to the homepage with your ACAM ID. If you navigate to the Hub section, you'll see that the Adverse Childhood Experiences Special Interest Group is listed there. And underneath, you'll see pretty much the content that Arnon just presented. So he doesn't need to share his slides. They're already up here. But we've got a clear mission statement there, which has been reviewed by members of the group. And if you like, this is the business for our online discussions. So anything that's relevant to these topics are things that we're keen to see people discussing on the forum. Below that, there's a little section about how to join the group, how to take part in the forum, and we'll look at that in a bit more detail just in a second. But I wanted to also highlight that there's quite a substantial new piece of content prepared by Arnon and his colleagues, a topic guide on adverse childhood experiences. So these headings, if you click on the little plus sign, it concertinas out into some quite detailed content around those subtopics within adverse childhood experiences. So there's what we don't know, applications to clinical work, and so on, down to reviewing 20 years of ACES research. So you can get access to that content via the Hub page. It's also in the topic guides within the ACAM website. So let's say I've logged in, and now I think this is great. I want to join in. What you need to do is to click the link in the Special Interest Group forum here. And this takes you through to the landing page for all of our discussions. So when we were planning this project, we were thinking, well, what people need is a way of discussing quite important and specific topics in a safe environment, where we're not using things like email threads, where people get left off the threads and then people end up talking at cross purposes with one another. Bringing all the conversations together and organizing them by topic is kind of what led us to think that a forum would be the right solution here. I know a lot of you be used to using forums. Some of you may be more used to these conversations on social media, but we felt that a lot of it is perhaps stuff that not everyone is confident discussing in the open on social media. So if you're not logged in and you're not a member of this group, you can't see the discussions that are going on. So I've created a test account. Here I am, DB tester up on the right. And I've already clicked a button on that page to apply to join the group. So if you want to join the group, you log in and navigate to this page. And instead of saying leave group, you'll see something that says request permission to join the group. That sends an alert to myself, and I will then check your application and approve your membership. So unfortunately, it doesn't happen immediately. We could set it up to happen immediately, but I think we like to have a check to make sure that we're not going to get people spamming the forum. So how the forum works is, I guess, like I say, some people will be familiar with how forums work. There's a list of topics, and it shows you what conversation has gone, how many people have replied to a topic, and when somebody most recently posted a reply. So if I wanted to create a new topic about social determinants, I might first review the forum to check it's not covered elsewhere. Think of my topic title that gets the message across, and you could just type your message in there, and it will be added to this list for everybody else to see. Some useful things to know is that if you're submitting a reply, if you click the little button that says notify me of follow-ups, then whenever somebody replies to it, you'll get an email telling you that there's been a reply. There's a couple of topics that we'd be particularly interested to get people's feedback on from the top. One is the Scottish Psychological Trauma Plan, which Aaron posted a topic on earlier in the week. We've got a link out there to the document, and again, you can submit your replies directly below by typing into the box. You can copy and paste from a Word document and things like that. So it's reasonably user-friendly. You can use formatting buttons at the top and things like that to make your message look nice. So that's how it works we'll click forum to go back home. So that's the idea. But we've created a discussion space where some of these quite complex issues can be teased out. We envisage pulling together resources. For example, one might have a resources thread where we update the first post of the thread when people suggest a new resource. Forums are a very, very good way of sharing those sorts of things. And you might have some plans for a project or something like that, and you want to get the opinion of people in the group. You can post a thread inviting people to give feedback on your plans. So that's the idea, a workspace where people can sign in with their ACAM details, and they can connect with colleagues who have an interest in the same field as them. One final thing to note is for not everyone here will be a member of ACAM, and why not, of course, but not everyone's necessarily going to go to that step. We have created a free sign up specifically for forum users. So if you click on the member registration, there's a form there where you can create a profile that will give you access to the forum. So that's it. I don't want to take up too much of your time. I'm really excited about this. I've really enjoyed listening to your presentations. Such a complex and difficult area, and so important. You know, it feels like to me there are economically dominant things we can do. We can invest now, and we will get benefits later if we can just frame those discussions in the right way. So I'll do whatever I can to support your work. You can use the forum to ask me any questions, or contact through the ACAM website will get to me and I'll try and help sort you out. Thanks very much for your time. Any questions, please fire them over.
Thanks so much, Douglas. So I don't want to go on for any longer because we're already past 3:30, but just wanted to say again a huge thank you to all of the speakers for such an interesting discussion and raising such great ideas. And hopefully we can take some of these ideas forward, hopefully in collaboration with you all and other lived experience users. And thank you to everyone for attending and asking such interesting questions, and look forward to future events and discussion as part of the special interest group. Have a great day, everyone.